Thank you for the opportunity to participate in GIE's author interview series. Today I will offer some insight into our article entitled A Survey of Expert Follow-up Practices After Successful Endoscopic Eradication Therapy for Barrett's Esophagus with High-Grade Dysplasia and Intramucosal Adenocarcinoma. This study arose from a desire to define appropriate endoscopic follow-up practices for patients with Barrett's esophagus and high-grade dysplasia and intramucosal cancer following endoscopic therapy. The number of patients treated endoscopically and requiring continued surveillance has grown significantly over the past several years, and yet follow-up protocols are not well established. In the case of Barrett's esophagus with high-grade dysplasia and intramucosal cancer, however, the growth of endoscopic eradication therapy has not been accompanied by evidence-based guidelines to help us establish the best post-treatment surveillance and follow-up practices. Our study is the first to shed light on some of these issues. We utilized a survey methodology to define an expert-based clinical framework of post-treatment surveillance practices based on the practices of experts in the field of Barrett's esophagus endotherapy. The survey tool that was used can be found in the article in GIE. As you will see in reviewing the results and discussion of our article, there were a number of interesting take-home points that came out in the study. I would like to highlight a few of them for you. EUS is commonly performed before endoscopic eradication therapy by most experts. In our survey, 95% of respondents performed pre-treatment EUS in patients with high-grade dysplasia and intramucosal cancer, and 55% of respondents did so even in the setting of high-grade dysplasia. Interestingly, 81% of participants did not perform surveillance EUS after endoscopic eradication of low-risk intramucosal cancer. Of the 19% who do perform EUS, 2 experts perform it every 3 months during the first year, and 6 perform a single annual EUS during this first post-treatment year. All respondents perform EGD for surveillance after eradication therapy. Regarding the interval of surveillance endoscopy after treatment of high-grade dysplasia and low-risk intramucosal cancer, the majority of experts perform EGD every 3 months during the first year. Almost all others perform EGD every 6 months during this year. Subsequently, the majority of experts perform endoscopy every 6 months in the second year and annually thereafter. Approximately 30%, however, will have discontinued annual surveillance or surveillance altogether after year 5. This pattern is consistent with the follow-up protocol used in the landmark ablation of intestinal metaplasia containing dysplasia trial, or the AIM dysplasia trial. During surveillance EGD, all experts perform biopsies of the normal appearing Z-line and neosquamous epithelium. After complete EMR eradication of Barrett's esophagus adenocarcinoma involving the lamina propria alone, only approximately 1/3 and 1/4 of the respondents refer their patients for CT or PET scan respectively. After complete EMR eradication of Barrett's esophagus adenocarcinoma extending beyond the lamina propria into the muscularis mucosa, 38% of experts refer their patients for consideration of surgical resection. In this situation, if esophagectomy was not an option, only 14% will refer their patients for consideration of chemotherapy and radiation therapy. When the adenocarcinoma is found to involve the submucosa, 100% of respondents refer their patients for consideration of surgical resection, and 82% refer the patient for consideration of chemo and radiation. Our study had the following limitations. This survey cannot substitute for primary research and subsequent evidence-based guidelines in this area. Our study sample was composed entirely of experts from the United States. Experts from other geographic regions may have varying practice patterns that reflect regional experiences, resources, and values. The process that we used to select experts was based primarily on the impact of scientific publications, which is only one aspect of expertise and certainly imperfect. The survey questions did not allow free text responses, perhaps failing to capture practice patterns not included in the multiple choice and table-based response choices. In this regard, there may be some blend or in-between patterns of surveillance that were not captured because they could not be described. The results of the current study may provide an impetus for future studies that will help define the optimal surveillance modality, EUS, CT, and/or PET, based on outcomes data and incidence of recurrence. Studies that would define the optimal intervals for surveillance. Long-term outcome studies defining the chronological and biological patterns of recurrence are necessary to determine whether the 3-month interval during the first year is necessary and cost-effective, what the optimal surveillance interval is in subsequent years, and whether surveillance remains necessary beyond 3 to 5 years. Determining the cost-effectiveness of these surveillance interventions. Multi-center registries from institutions and practitioners who perform surveillance EUS are necessary to determine whether the clinical yield of this practice justifies the associated opportunity and economic costs. Moreover, long-term outcome studies are necessary to determine whether earlier detection of recurrences by EUS actually improves clinical outcomes or simply increases apparent survival through the phenomenon of lead time bias. Defining the surgical indications of low-risk intramucosal cancer extending into the muscularis mucosa. Additional clinical studies and simulation models focusing on the risk-benefit ratio of esophagectomy and/or chemoradiation in this scenario are necessary. In the interim, practitioners should be clear about the elevated risk of lymph node metastasis associated with muscularis mucosa cancers so that patients can make an informed decision regarding surgery. In summary, our study is among the first to provide insight on the surveillance patterns and practices after endoscopic therapy for Barrett's esophagus in the setting of high-grade dysplasia and intramucosal cancer. I would like to thank my co-authors at the University of Michigan. This study not only reflects my efforts as a GI Fellow, but also the collective efforts and intellectual contributions of my mentors. We are certainly honored by the opportunity to have it featured in GIE. Thank you.